How'd you do that?
Yeah, man. Yeah. Ah, jaywalking. Yeah. So all my fault. It's good now.
We need to
Okay.
come up with a better story for you.
It's humorous and I brought my humors. Yeah.
Yeah.
No, I was flying down the Black Diamond Run. Yeah. No, I was doing something illegal. Anyway, okay, we will behave now. Shall we start recording? Hang on, where's my recording button? Okay, all right. Okay, all right. We shall be serious and start now.
Recording in progress.
Thank you everyone for joining us today. I'm delighted to have Alex Kemper present on Jaundice. Alex, if you don't know him, is now the the editor-in-chief of Pediatrics, the official journal of the AAP, and he's the division chief of primary pediatrics, correct me if I'm wrong, Alex, from Nationwide Children's Hospital in Ohio. He was the lead of the AAP revision of the Jaundice guidelines for the United States that came out in 2022. I'm sure it was an incredible effort where it took probably years out of your life. And having just done the New South Wales guidelines ourselves, I can't imagine what you would have gone through because we copied from you. So we're very, very keen to hear your thoughts on what is left to be uncertain and controversial about neonatal jaundice. And for those online, you will be muted. But if you have any questions, please place them in the chat for Alex to answer at the end of his talk, or unmask yourself at the end. We will have about 10-15 minutes for Q's and A's after he finishes. So without further ado, Alex, thank you so much for presenting, and the floor is yours. Thank you.
Thank you so much. I'm just really excited to be able to talk with you about our experiences putting together the guidelines and to talk about some controversies and uncertainties in neonatal jaundice. As I go through, if there's something that I say that doesn't make sense or you want me to elaborate on, please just take yourself off mute and shout the question out. I just want to make sure that this is interactive as possible. So sadly, I have no disclosures, and I'm not going to be talking about anything that's off-label over the next hour. And I do want to give credit to the rest of the gang, the rest of us who worked on the bilirubin guidelines. And I promised Julie that I would tell the story of how I got involved, and I'll do that over the course of my presentation. So in terms of learning objectives, by the end of this presentation, I hope that you're able to break down the 2022 AAP guideline and understand the rationale for several parts of it, to identify our challenges, to list lessons that we've learned since the release of the guideline, and to use this to infer future research opportunities, and ultimately light the way to kernicterus prevention. And what was funny is in the minutes before I began to present, I was looking at this slide and I realized, look at that. Actually, I took about an hour to figure out how to make that spell out Billy Light, but there we go. So as everyone knows, the focus of my talk is going to be on unconjugated hyperbilirubinemia. I'm not going to be talking very much about the issue of conjugated hyperbilirubinemia. And as everybody on this call knows, the issue is related to the breakdown of heme and ultimately to bilirubin. So why do newborns develop jaundice? Well, newborns have an increased bilirubin load at birth. They have babies can develop an increased bilirubin load at birth because they have a higher red blood cell mass and a decreased red blood cell lifespan related to fetal hemoglobin. And they also have decreased clearance. There's decreased conjugation because of lower activity of the enzyme that's responsible for doing that. And babies have increased enterohepatic circulation. Now, Making matters worse are issues of hemolysis that can happen with ABO or RH incompatibility, RBC, red blood cell membrane defects, red blood cell enzyme defects. And I'm going to be highlighting later in the talk issues of G6PD deficiency. And then newborns can also have issues with decreased clearance due to poor feeding or other enzyme defects. And ultimately, again, as everybody knows, Carl knows, our goal is to prevent kernicterus, which the hallmark is the pathologic finding of yellow staining on the basal ganglia and often other areas of the brain. Kernicterus, when it does develop, is irreversible, and it's caused by free bilirubin crossing into the brain. That is bilirubin that's not bound to albumin. Now, kernicterus typically is described as occurring in two phases. There's acute bilirubin encephalopathy that begins with lethargy, some hypotonia, and an abnormal cry, proceeding to stupor, hypertonia, poor feeding, and an abnormal cry, and then ultimately coma in some infants, retrocalis opisthotonus, and seizures. And then that leads into chronic bilirubin encephalopathy, which is what we refer to typically as kernicterus, with hallmark problems including chorioathetosis, upward gait palsy, sensorineural hearing loss, and auditory neuropathy. Interestingly, there's also dental enamel hypoplasia that's associated with chronic bilirubin encephalopathy. We don't have great data in the United States about the epidemiology of kernicterus. This is from a study that was recently done looking at data in one large health system in California that showed that overall the incidence of kernicterus is low and was getting lower since the early 2000s. I hesitate sometimes to show this slide, especially with trainees, because it's easy to look at this and say, kernicterus is really rare. Why do we have to worry so much about it? And obviously, kernicterus itself is a terrible condition. And then the other thing is that the rates of kernicterus, the incidence of kernicterus is really low because, in fact, we do so much work to prevent it. So I just think that we have to be cautious when we talk about these kinds of data. Now, Julie, when I asked me, so I was putting these slides together to talk about the top research opportunities, things that we identified as we were working on the guideline that I kind of wished somebody would resolve. So I did put together a list and I ordered them, although you could argue about the way that I ordered them. And I'm sure you all will look at this and say, oh, well, he left out this really important thing. So hopefully we can talk about that at the end. Here's my David Letterman style list. So I have number 10, laboratory variation in total serum bilirubin measures, and I'm going to be talking about that. I wish that we had more precise estimates of the risk of developing kernicterus based on the current total serum bilirubin or transcutaneous bilirubin, that is TSB or TCB, that a baby has. When I got pulled into the guidelines, I thought, oh, well, this is going to be pretty easy. We'll be able to look at factors related to the infant and then whatever the current bilirubin level is and understand the risks and benefits of intervening. But we just don't have that kind of granular data. Again, nobody on this call is surprised about that. I wish that we had a better understanding of the role of albumin concentration and the bilirubin to albumin ratio when making decisions about treatment. And again, I'm going to be talking about that a little bit later. Timely identification of G6PD deficiency is challenging. So before I began the talk this evening, I guess this afternoon for you all, we were talking about how Singapore has a test for G6PD deficiency around the time of birth. In the United States, New York, the state of New York has a mandate for doing this, although it's not universal screened. They use some factors to decide which babies require point of care G6PD deficiency testing. But figuring out how to identify G6PD deficiency in a timely way, I think, is an important challenge. But related to that is the impact of knowing G6PD deficiency status. So we recommend the universal precautions related to G6PD deficiency, but I wonder how much better those precautions work when you actually know what the status is of the baby. And again, I'm going to be talking about this in greater detail in a few minutes. I think that there's some really interesting and exciting work going on around the effectiveness of continuous versus cycled phototherapy. Again, that's up for later. The role of home phototherapy, accuracy of transcutaneous bilirubin measures after phototherapy, the accuracy and the role of smartphone assessment of jaundice. So there's a lot of interesting and exciting work going on around using smartphones to assess bilirubin status. And then one of the things that our guideline is silent on is the management of infants who are less than 35 weeks gestation at birth. So again, our guideline is for the late preterm through full-term infants, and we're really silent on the premature or the preterm infants. But I do have some additional opportunities that are sort of cross-cutting that I want to make sure to bring up, which is the first is standardizing terms. I think that there's a lot of confusion around some of the terms that are widely used in the sort of the world of bilirubin, including bind, bilirubin-induced neurologic dysfunction, which can variably refer to a scoring system or more subtle conditions associated with bilirubin, high levels of bilirubin. So I think that creates some confusion, and I think that there's opportunities to do that. I'm very excited about engaging practices in quality improvement collaboratives because I think it's a rapid way to learn and also to reduce inappropriate variation. Shared decision making. It would be great if there were formal ways to engage families when for example, the bilirubin level is close to the phototherapy threshold. And again, I'm going to talk about this a little bit more. Registries. As somebody who spent most of my career outside of the world of bilirubin, I was surprised that there are not large-scale kernicterus registries, and I think that we are missing opportunities to learn because of that. And then the guidelines that we developed were not really developed for low and middle income countries. And I think that there's a lot of exciting work that are going on in low and middle income countries. And I think that we could all really benefit from working together. I think that there are important lessons to be learned. So now I just want to talk a little bit about the history of the guideline and how I got involved in the guideline and how things evolved. So this is a great Jeopardy answer if you're ever on Jeopardy, and that is that the American Academy of Pediatrics' first clinical practice guideline that they released was the 1994 guideline for the management of hyperbilirubinemia. And as you all have seen, the current guideline is quite long. This was essentially the entire guideline in one little table. So it broke things down into age and hours, and then had thresholds for when phototherapy should start and when exchange transfusion should be done. And this was, for all intents and purposes, the entire thing. Now, as I just want to point out that this slide has both milligrams per deciliter as well as the SI unit of micromoles per liter. And I'm just going to apologize in advance that for most of my slides, I'm going to be using milligrams per deciliter. And I hope that's not too confusing. But basically, to get back to the talk, this was the very first AAP guideline. Now, in 2004, the guideline was updated. And the big innovation to the revision of the guideline was this risk assessment nomogram, which is sometimes referred to as the Bhutani nomogram because it was developed by somebody by the name of Vinny Bhutani, who actually worked on the 2022 guideline. But what you can see is it breaks down risk by postnatal age and what the bilirubin level is into a low risk zone, a low intermediate risk zone, a high intermediate risk zone, and then babies who are above the 95th percentile. That guideline recommended that infants receive some measure of bilirubin before discharge so that the risk could be plotted out. And then it was tied to this figure, which shows the phototherapy and the exchange transfusions thresholds, and those were stratified based on the risk from the nomogram to the left. So you can imagine that this created some problems in that it was not uncommon for clinicians to look at the nomogram on the left and get confused about that and the treatment thresholds, so that there were babies who were being treated based on the risk nomogram instead of the phototherapy and exchange nomogram. So that had sort of evolved as a point of confusion. There were other problems with the risk-based nomogram, and that's that it didn't take into account gestational age or antibodies based on the infant's direct antibody test results. It focused on predicting who is above the 95th percentile, but being above the 95th percentile is not the same as needing phototherapy or exchange transfusion or anything like that. It's not being above the 95th percentile on this risk curve that is tied to treatment. That's based on should be based on your risk of developing kernicterus. And then, as I talked about before, with the confusion, it required plotting the bilirubin level twice, on the risk-based nomogram as well as the phototherapy or the exchange transfusion thresholds, and that just caused problems. So, as I promised Julie, I would talk a little bit about this. The guideline committee was formed, and it really included most of the same cast of characters who had been working on the previous two guidelines, the ones that I just described. And there were some areas where there was a lot of debate. So there was this recognition that there was an opportunity to raise the thresholds for phototherapy, but they were having trouble coming to a consensus. And I knew a bunch of the folks, and they decided that I was good at helping people come to consensus. So I was asked if I would come in and just kind of help the group go through a process to come up with the appropriate thresholds, and that it would probably only take like a few months for that process to be done. So, Julie, do you want to guess how long it actually took?
3 months.
It did not take 3 months. It actually took 8 years.
We don't feel so bad then.
Yeah, 8 years. But I'll tell you that it was, because the old system with the risk-based nomogram that was generally working, there was some resistance to changing. But When I came on, I really thought that there was an opportunity to simplify and clarify the guidelines. Now, you could argue whether or not we simplified things or not, but it was really my goal going into it to make things easier for busy clinicians. And so um, that's why there are a bunch of changes, including removal of that risk-based nomogram and building some other things into the phototherapy and exchange transfusion thresholds that required less mental gymnastics. And then again, the thresholds were raised a little bit. Let me talk about that in a little bit. So I want to walk through what I think are some of the important parts of the guideline. So the first part is the recognition that kernicterus prevention really starts before the baby is born, with checking the maternal antibody screen, and then if that's positive, checking the infant's DAT as soon as possible, and then sorting out whether or not this is really an important antibody. For example, it could be positive if the mother had previously received ROGAM. And if it turns out that the baby really does have uh, uh, significant antibodies, sorting out what those are, but also making sure that the baby is monitored much more closely for elevations of bilirubin early in life. And I mentioned to Julie before we started that I still get emails at least 2 or 3 a week, and this is one of those areas that I still get questions about, and I'd be happy to talk more about it is at the end of the presentation. Related to issues around the prevention of hyperbilirubinemia, we recommend adequate breastfeeding support and avoiding oral supplementation with water or dextrose water, which has not been shown to reduce bilirubin levels. In the guideline, we talk about 2 different kinds of risk factors. So we talk about risk factors for hyperbilirubinemia in the first place, and these include things like lower gestational age, if a baby has jaundice in the first 24 hours of life, or elevated bilirubin levels close to the phototherapy level. Again, that's not a surprise. Hemolysis, all these things are related, but and I'm not going to read the whole list, but we point out risk factors for hyperbilirubinemia. And separate than that, we talk about hyperbilirubinemia neurotoxicity risk factors, which is quite a mouthful, especially for me because it's getting up to midnight here. So you're probably going to hear me refer to them just as neurotoxicity risk factors. And these are factors that, if present, make it more likely that you could develop problems even at the same bilirubin level. So if you have a lower gestational age, lower albumin, I'm going to talk about some of the controversies that we had around that. Isohemolytic disease, G6PD, or another hemolytic condition. Sepsis or significant clinical instability in the previous 24 hours. While we were working on the guideline, we really kind of went on this false path, I think, for a little while, where we were trying to define sepsis or clinical instability in a very formal way. But we realized we were just going in circles, and these guidelines are developed for experienced clinicians. And so for us to spend a lot of time trying to explain what clinical instability is, for example, is just kind of it's just too hard of a task. And my personal feeling as we were working on the guidelines is that those who are taking care of these babies are experienced, smart people, and we shouldn't second guess them or overly micromanage them. So we do try to leave things to your good judgment, and this is an example of one of those areas. Now, I will say that this issue of albumin and G6PD deficiency created some problems. So let me first talk about albumin. We wanted to put a number in the guidelines of like when albumin was low enough that you needed to worry about it. And ultimately, we carried on this threshold of 3 grams per deciliter because it was in the 2004 guideline. Where it said it's an option to measure serum bilirubin level and consider an albumin level of less than 3 as one risk factor for lowering the threshold for phototherapy use. So we really just kind of carried that number on. The guideline, this is one of those areas that I get questions about. The 2022 guideline does not say that you need to routinely measure albumin, but if you happen to have measured albumin because you're otherwise worried about the infant, if it turns out that it's low, then you need to think about that as a neurotoxicity risk factor. I'm not sure that the number 3 is really all that magical, and we probably could have put it lower because, as I have here, upwards of half of all infants will have a serum albumin concentration of below 3. So the other point I want to make about albumin is that albumin is not a hyperbilirubinemia risk factor. It's just a neurotoxicity risk factor. And if your only issue, I mean, typically babies who are going to have low albumins will have other things going on. But if you're just below 3, but everything else is fine, most of those infants will have a robust response to phototherapy. I do want to just outline some of the causes of significant hypoalbuminemia, just to point out that babies who have really, really very low significant hypoalbuminemia, they'll be sick, and you'll know that for other reasons. So fetal perinatal hemorrhage due to fetal maternal transfusion, twin transfusion syndrome, the donor twin. Can have significant hypoalbuminemia, anemia and polycythemia sequence in twins, anemia due to malformations of the placenta or the umbilical cord, significant blood loss after birth, congenital nephrotoxic syndrome, hydrops, congenital chylothorax, gastroschisis. All these things can lead to significant hypoalbuminemia. And I just point this out to say that you all as busy clinicians would recognize when these features are present. The other issue that we spent a lot of time talking about, and I still don't think, I think a lot of work needs to be done in this, is related to G6PD deficiency. So the issue with G6PD deficiency is that infants who are exposed to oxidative stressors can develop massive hemolysis, leading to very rapidly rising and very high levels of bilirubin. The one baby that I've seen who actually developed kernicterus was during my residency training. It was a baby where there was no family history of significant hyperbilirubinemia, and the family had a tradition of every time a new baby came home, they pulled out a family heirloom blanket and wrapped the baby up in the blanket to take pictures. And as you all can guess, that blanket rather was stored in mothballs. And so when they wrapped the baby who had G6PD deficiency in this blanket, the baby developed massive hemolysis and came into the emergency department with bilirubin level that was above 35. So, and that baby did develop kernicterus. So, generally, what we do in the United States, and again, I'd be interested at the end to hear other people's thoughts, is universal prevention in terms of counseling about avoiding exposures. Um, but I do wonder about the degree to which knowledge of whether an infant has G6PD deficiency would improve outcomes if parents would be, um, more likely to be able to avoid oxidative stressors. The obvious answer seems to be like, well, yes, of course, but I think that I, I think that there's an opportunity to study that. Um, I don't have it in this slide set, but recently New York has a mandate that all newborns based on um, uh, genetic ancestry should be tested for G6PD deficiency. But the way that the legislation is written, and because of the population in New York, I know that several large health centers now have just decided to universally screen all newborns for G6PD deficiency. And we're still waiting to learn about what their experience is. But I think those lessons are going to be very instructive for future versions of the guideline. In terms of measuring bilirubin, the guideline specifies that total serum bilirubin is the definitive test in terms of making decisions about providing care. And there's the recommendation to, if you're using transcutaneous bilirubin, to measure the total serum bilirubin level if it's within 3 milligrams per deciliter of the phototherapy level or above 15 milligrams per deciliter. Just because those are places where the accuracy curves separate. And the guideline also now specifies that bilirubin should be measured 24 to 48 hours after birth or before discharge if that occurs earlier. And that total serum bilirubin should be used if the infant received phototherapy within the past 24 hours because of concerns about the accuracy of transcutaneous bilirubin measurements if the baby is recently exposed to phototherapy. I do want to acknowledge that um, there have been studies, and some of the studies have come out after our guideline work was done about how it's probably safe to use transcutaneous bilirubin measures after exposure to phototherapy, especially if these little skin coverings, these clips, have been used. But at the time of the guideline, the consensus was that the evidence wasn't strong enough to recommend that it was okay to use transcutaneous bilirubin measures. So there is this issue of variation in TSB measures, and the differences can be pretty dramatic. It can be as high as 30%, and there's lots of reasons for why this may happen, including the way that the samples are handled, including exposure to light, and variations in laboratories due to assay-specific factors and how things are calibrated. I'm not a laboratorian, and so I don't want to get too much into the details about why this calibration and assay specific factors sort of play into it, but just want to point out that this is been a well recognized thing. When we were, and this actually played into when we were setting the phototherapy and exchange transfusion thresholds, we wanted to be a little cautious, knowing that there was this variation, so that infants would still be safe even if there were TSB came back that measured in a different lab would have been higher, so like a falsely low TSB. And this has been known for a really long time. So here's an article from 1982 And it's so interesting. I'm going to quote from the discussion section here that the results of the study demonstrate the lack of accuracy of serum bilirubin measurements, especially at the high concentrations seen in some newborn infants. These results probably will not be surprising to clinicians. The results reported here are consistent with the suggestion that little or no improvement in interlaboratory bilirubin results has occurred in the past 20 years. So again, that would take you back like 60 years, at least for elevated bilirubin concentrations. So I'm not sure why this is so much of a problem. And I hope somebody can, illuminate me about this at the end of the talk. This is the figure that shows phototherapy during the birth hospitalization. Obviously, if the total serum bilirubin level is above the phototherapy threshold, then phototherapy should be started. And if that is not the case, then we have a series of recommendations about follow-up based on the differences between whatever the phototherapy threshold is and the bilirubin level threshold, as well as the age of the baby. I'm not going to read this whole table. But I do want to focus here on the phototherapy side of things. Let me just move it in here, so I tried to line this up just so that you could see the relationship between the thresholds on the left with no hyperbilirubinemia and neurotoxicity risk factors other than gestational age. So gestational age is baked into the figures. But if you have an additional neurotoxicity risk factor, then you use the figure on the right. And, it took a long time to come up with this in that in looking at the sparse data that were out there, there were some members of the committee that were more liberal and others that were more conservative. And this is really the results of a consensus. I'm just going to move on to this figure in the interest of time, which illustrates gestational age and the age of the baby in hours, and then the evolution of the phototherapy threshold. So this is for babies with no neurotoxicity risk factors. And you could look at this, and if you compare the 2022 thresholds to the 2004 thresholds, you might say, well, that's not really a big change, but from the data that's emerging from some of the national quality improvement collaboratives, there's been a dramatic decrease in phototherapy in the order of like 30 or 40%. And here's a similar table that shows phototherapy thresholds when there's a neurotoxicity risk factor other than gestational age. And you can see that these are still fairly conservative. Of course, the 1994 guideline was silent on the issue of neurotoxicity risk factors. There are other guidelines out there, and I just want to highlight the ones from the UK that were developed in 2010. A little bit less nuanced. You can see just the flatness of the curve. The NICE guidelines include curves that go down to, I think it's 23 weeks gestation as well, based on predictions around what the bilirubin level load is at birth and some other mathematical decisions. But I do like to put this up there just for comparison purposes. In terms of the use of phototherapy, the guideline is very specific around the wavelength of light and the intensity and how it should be used. And I'm not going to spend a lot of time on that, but just to highlight that the amount of the body surface that's exposed is more important than the number of devices, and that you don't have to change the infant's position if it's going to put them into an unsafe sleep position. I do think, and this is getting back to the issue of research opportunities, um, uh, there are different ways of applying phototherapy. It can be done continuous, which is uh, uninterrupted. And certainly, if you've moved into the escalation of care part of the guidelines, that's what you would want. Continual, which allows brief interruptions, for example, the baby to go to the mom for feeding. And then there's intermittent, or sometimes referred to as cycled phototherapy, which is being studied, and it does appear pretty promising. And you can imagine that this might be one of those things that would really benefit families. There was a Cochrane review from 2023 that included 12 randomized trials and 1,600 infants. And across the studies, there was tremendous variation in terms of how phototherapy was applied intermittently. They found little or no difference, though, between the intermittent use, or the cycling, versus the continuous, but the certainty of evidence from that Cochrane review was described as low or very low. So certainly an opportunity there for future research. And I should say there are studies that are going on. We, in the guideline, talk about additional phototherapy safety considerations. Again, for the purpose of the talk, I'm just putting this up there, but I'm not going to talk at length about it. But just to highlight, to remind people to make sure that their phototherapy devices are calibrated. So all of the devices have explicit rules around how things should be calibrated, and you just want to make sure that that's really done. In terms of laboratory testing during phototherapy, I already mentioned that we recommend just using TSB. We recommend that when you're starting to measure a hemoglobin or a hematocrit or a CBC, and that's because if the baby's having significant ongoing hemolysis, it's kind of nice to know like where you were. And then begin with get a total serum bilirubin level within 12 hours of starting phototherapy. For home phototherapy, we were pretty conservative in terms of recommending total serum bilirubin levels daily, and admitting if the TSB seems to be increasing, where you're kind of losing the battle related to where the phototherapy threshold is. And this gets into the issue of what do you do if you are near the phototherapy curve. If you're going to use phototherapy because you can just, the writing is on the wall that you're going to get there, and decide to use subthreshold phototherapy. I see, at least in the community that I live in, I see people using home phototherapy a lot. This gets into, I think, issues of shared decision making too, in terms of the degree to which families would rather initiate subthreshold phototherapy to avoid potential rehospitalization, or if they'd rather just stay in the hospital and be done with it. Another area that I get a lot of questions about is around discontinuing phototherapy. So we recommend actually it's an option that when the total serum bilirubin level is 2 milligrams per deciliter below the threshold at which it was started, your risk of rebound hyperbilirubinemia is really low, and so that's where we recommended stopping it. But the problem is if you start phototherapy when the baby is quite young, getting 2 milligrams per deciliter below the threshold can be really, really difficult. And so we list in there other calculators that you consider using to understand what the risk of rebound hyperbilirubinemia. And we provide guidance about the role of getting a repeat bilirubin level after phototherapy. If the baby's at high risk, certainly you want to do it sooner. Otherwise, the next day is usually fine. We introduced this new term into the guideline, escalation of care. Escalation of care is when you get, when you're getting dangerously close to the point of needing an exchange transfusion. And, the clinical data are pretty clear that if you're getting into the, the risk of needing an exchange transfusion, if you're really aggressive in terms of phototherapy and IV fluids, you can really reduce the risk of needing an exchange transfusion. And here are the exchange transfusion thresholds. And again, I tried to line them up based on whether or not the baby had a hyperbilirubinemia neurotoxicity risk factor or not. And I'm just going to, again, I'm going to make sure that we get to the questions. This is the table that I showed before in terms of the follow-up after newborn hospitalization. A lot of work went into coming up with these thresholds. We were lucky to have a large clinical database to model what the risk was based on various cutoffs. And I'll just refer you to this other paper that describes where those numbers came from and why they were chosen. And I see a lot of questions coming up, so I want to really kind of move through. So there's some options to remember. We talked about subthreshold therapy. We talked about home phototherapy after discharge. Again, we're fairly conservative about the use of home phototherapy. I can tell you that in my community, getting a home phototherapy device out in a timely fashion can be complicated, and it's just easier in general to provide the phototherapy in the hospital setting. Again, that's hard for families, I recognize. The issue of smartphone technology for assessing bilirubin, I think, is really, really exciting. It's a complicated area, and I can talk about it more during the question and answer period if you'd like. But I think that there's several questions. One is related just to the accurate screening, and then the other is the impact on the information on care delivery. So how exactly will it be used? What will families know about the results of their use of their smartphone to measure their baby? I mean, you can imagine, I have some families in my practice who, if they had this, they'd be checking the baby's bilirubin level every 2 minutes. So sort of figuring out, how that's going to play out, I think, is a really interesting question. One of the places that families can get in trouble with is having poorly coordinated care. We spend a lot of time in the guideline talking about the need to educate families and to arrange follow-up. But, I do worry about those babies that are, discharged and need to have like a follow-up on Sunday. So a lot of the practices in our town are open on Saturday, but finding practices that are open on Sundays is a little bit more challenging. And the other thing is that, there's risks related to just poorly communicating the baby's hospital course and the degree to which they need to be followed. Again, our guideline is silent on babies with gestational age of less than 35 weeks. I mentioned that the NICE guidelines have some thresholds. In talking with others, point neonatologist to this article that was published in the Journal of Perinatology, but it's quite old now. So this is from 2012, but it provides some thresholds. But these are all based on expert opinion. Again, I'm a general pediatrician who's not spent most of my life focused on bilirubin, but it's interesting to me that that this sort of gap in evidence around the around preterm infants. Prolonged jaundice is an issue, especially in terms of when you get concerned about a conjugated hyperbilirubinemia. Although that's not the focus of the guideline or the talk, we do provide some information about when to consider remeasuring the bilirubin level. But recognize that the breast milk jaundice syndrome, which is unconjugated hyperbilirubinemia, can last up to 3 months and it's not pathologic. So has the guideline worked? Well, there's evidence that's emerged, and I put some of the studies out here showing that there's a decreased risk of rehospitalization for jaundice or phototherapy. There's been a decreased length of stay during those rehospitalizations. There's been, from the studies that have been done, no statistically significant change in the incidence of kernicterus, but that's a hard outcome to assess because kernicterus is fortunately so rare. So I have like funny slides, but I'm not gonna spend time talking about them, and I'm gonna stop sharing so that I can see you all. I hope you found this helpful, and I'm of course happy to stay on and answer questions. And hopefully I won't turn into a pumpkin at midnight.
Thank you. Well, we'll cut you off and have you for pudding. Thank you so much, Alex. That was great. Look, before we go on to the questions, there's lots of questions about how to multiply by 17, but we'll go straight to Alvin. Alvin, who developed an AI informed Billy app while I curate the questions for you. So Alvin from Singapore. It's Singapore, the land of jaundice. So go, Alvin. Can you unmute yourself?
Hi, good morning, good afternoon, good evening, everyone.
Yeah, whatever. Yeah.
My name is Alvin. Thanks, Prof. Julie, for allowing me to share Billy SG, if I may have 3 minutes of your time. My name is Alvin. So sorry for the noise. My name is Alvin. I'm a clinical assistant professor from Singapore General Hospital. I did my fellowship with Prof. Cheryl, who is online as well, in Royal Women's Melbourne. So we are talking about smartphone jaundice apps that can help to screen babies for jaundice, because jaundice is a problem that's worth solving. It's extremely prevalent. We talked about how important it is. We wanted to solve 2 problems. One was a lack of screening in developing countries, and the other had to do with a very cumbersome screening program in developed countries. It is estimated that in Singapore, the annual economic burden of screening for jaundice is in excess of $20 million a year. And particularly in Singapore, the average data is that on average, babies have to attend the polyclinic in person 5 times in the first 2 weeks in a crowded polyclinic. So most parents would prefer not to go to the polyclinic and would rather stay at home if possible. So that's where our solution came. Our solution is called Billy SG. It is grounded on the Kramer's principle, which everyone here is familiar with. It states that as the serum bilirubin goes up, this is correlated with the cephalocaudal progression of thermal icterus. So we merged this with cutting-edge machine learning techniques and a proprietary color calibration card to create Billy SG. So the video on the right shows how Billy SG works. We use the color calibration sticker, and we use the central aperture to take the photograph from our app. We repeat the process from head to toe. So what happens is that features are extracted from these photographs. The features are processed on a cloud-based machine learning model, and out comes the smartphone predicted bilirubin. At the point of publication, it was the largest study. Now it is the second largest. There was excellent correlation with the gold standard serum bilirubin, Pearson R of 0.84. In terms of sensitivity for a decision rule, it was 100%, and specificity was 70% compared to transcutaneous bilirubin in our study. We published our findings in JAMA Network Open. In terms of competitive landscape analysis, as we are all familiar with, blood tests is the gold standard, but it is invasive. transcutaneous bilirubin is increasingly being used as the first-line method of screening. It is non-invasive, but the use is largely confined to medical facilities. So necessarily to have a non-invasive and scalable method of screening, we have to consider the use of apps. So what's out there? So BilicSG amongst the apps is superior for several reasons. Firstly, we are the only app that is adhering to the all-important Kramer's rule. With the Kramer's rule, it is imperative to take photographs of multiple regions from head to toe, whereas the other apps only take one, and theoretically can generate different values depending on the region of interest chosen. Secondly, we are the only app that is specifically trained on and performs well on multi-ethnic babies. You can see that our Pearson correlation in subgroup analysis is very consistent amongst different skin tones, whereas the results can be variable for the other apps, depending on which population it is applied on. In terms of accuracy, scientific rigor, this is absolutely important, especially when we talk about responsible AI. So the industry standard would be the Tripod AI 2024 statement. And out of 27 possible points, we scored 25. And we are by far the leader in terms of scientific rigor, ahead of the other two closest competing apps. We have an advisory panel that comprises experts in pediatrics, primary care, implementation science, data science, AI, medtech innovation, regulatory approvals, regulatory medicine. And we also have a clinical team that comprise pediatricians from all three major public healthcare institutes with pediatric departments: Singapore General Hospital, KK Hospital, National University Hospital. We also have primary care physicians in both clusters, National University and Sing Health polyclinics, because they are the ones who primarily take care of babies in the community. We also have experts who are from the data science department in Synapse in Singapore. We have experts in implementation science and health economics and ergonomics as well. So we will start in Singapore because we are a national AI project under the Ministry of Health, and we have the support of the minister. We have previously documented that we have buy-in from parents. We have a qualitative study that showed that parents in Singapore were very keen to have such a program implemented in Singapore. So this is our proposed program. We propose by next year to have a pilot called Neonatal Jaundice at Home, where instead of parents having to bring their babies down to our community polyclinics for checks, and as I shared earlier, the average was 5 times in the first 2 weeks, we will allow them to use the app to check the baby's jaundice at home and come down if necessary. So we operate as software as service and software as medical device, and we currently have plans to actually head out of Singapore, including to Australia, and currently we have plans to work with Arun and also Prof. Cheryl to try this out in Australia, do trials. In the pipeline, we so far have only a proof of concept study that was published in JAMA Network Open. We plan to upgrade BilicSG into 2.0, which is a minimum marketable product. This will address the issue of generalizability across a wider range of phone models, not just iPhone, but Android, wider range of patients across a wider range of skin tones, a wider range of physical and lighting conditions. We also will conduct an implementation science study where we will interview parents, administrators, as well as end users to find out the facilitators and barriers to real-world rollout. And all these will culminate in the first of its kind in the world pilot study where such an app will be used on a large scale in the community in the safety and comfort of the parents' homes. Thank you very much for your time.
Thank you so much, Alvin. Could I ask, okay, Alex, what are your thoughts about that? Smartphones, AI.
Yeah. I'm very keen on that stuff. Alvin, I think that that's great work. I'm very excited to see where that goes. I think you alluded to this, and I'm excited to see how it works in terms of the way that the information will be shared from when the family tests to the to letting the clinical need team know, and how that'll feedback to the families. And I can tell, you only had like a few minutes to talk, but I could tell that you're thinking a lot about that, and I think that that's going to be one of the most exciting things about it.
Absolutely, Prof. So we have a task force specifically looking at implementation science. Having the tech itself is not useful. Having clinical and digital integration of the new tech that is validated into the current working system is crucial and imperative. So that's what we're focusing on.
Excellent.
That's great. Thank you. Look, we've got quite a few questions apart from learning how to multiply by 17, right?
Well, it's too late for me to, it's too late at night for me to do the 17. Do you want me to just hit some of the questions that are in here?
Choose which ones you want, right? So
I'll just say, the person who asked about how the calculation for the NICE guidelines, I'm 98% certain that that's correct. I know, I mean, it looks right, but I'm too tired to like say that that's correct. In terms of the Kramer rule and like why things move from north to south, I was actually really interested in that, and I tried to explore that in the literature, and I couldn't find the answer. So if anyone figures it out, let me know. The question about do you need to use an adjunct to phototherapy? So there have been, some compounds that have been studied, like there was tin, was it mesomorphin, that didn't seem like it looked like it was effective. What I would say is that in nearly all infants with hyperbilirubinemia, that if you apply phototherapy as directed in the guidelines, things will be okay, and that you don't really need to do anything else. And when you move closer to the exchange transfusion, the addition of the IV fluids really does make a difference. We didn't talk about IVIG.
Oh, that little bugbear.
Before, which is like a whole complicated thing. But if you have a antibody-mediated reason for having the hazardous hyperbilirubinemia, there may be a role for IVIG there. Robert commented that the math was correct, and he came up with it in 1992. So
Robert
that's
is our chief neonatologist.
Oh, see, I want to hear that story. If I had, yeah, exactly, over a beer. So, if I had known that the person who came up with that rule was on this call, I would have been quiet and had that person talk. And I think, did I hit the major ones? Oh, I'm gonna scroll up. Yeah, 17. There's, I think, David Baker asked about DAT. In ABO hemolysis and the sensitivity of it. What I can tell you, this is, I didn't talk about this during my presentation, but in the same way that there's variations around bilirubin results, there's also variations in how sensitive DAT tests are. And I'm not sure why that is, but there are some that are much more sensitive to than others. And I think that given this issue, you need to just be thoughtful about the babies having bilirubin levels that's rising faster than you would expect. Even if the DAT is negative, then you have to dig into this further. Let's see, Rita Horvath just asked, provide some information on standardizing things. I think that's really critical.
We have Tina. If you have time, a few more minutes, I promise Tina, who's our chemical pathologist, who's very concerned about the variations in our testing. I don't know how do you guys handle that in the States? You massive population, everyone's probably got a different number. Could we, Tina, are you able to talk a bit on your concerns about our variation in point of care testing?
Yes, hi, Alex. We looked at the variation between the lab and the point of care at each facility, and as you would guess, it varies because there are so many manufacturers of each type. But the only variation that matters to a neonatologist is the variation at their own facility, their own blood gas bilirubin and serum bilirubin. Now, while there are standardization initiatives that are occurring to try to align the manufacturers with the bilirubin standard, that will take some time. In the meantime, we probably need a more quantitative correction factor, which is going to be specific to each location. to assist the specific neonatologists. For some, we've found within New South Wales in Australia, we've got some sites where the blood gas bilirubin overreads by 30 to 70 micromoles, which is 3 to something. Sorry, milligrams per deciliter. And then at another facility, it's the other way around. So the amount of confusion is enormous for clinicians, and this is part of the issue, helping them understand.
It's really shocking, don't you think, that there's this kind of variation? I had no idea before I started doing this guideline work. But thank you for that. And I think that there are lessons we can all learn from the work that you're doing. So I really appreciate it.
Yeah, we usually blame ourselves. So the blood's been squeezed too hard, or, been sitting down in the sunlight or something, right? But yes, the variations are quite enormous. And we have some hospitals that read too high, some that read too low. And, it's really, has any harm been done? I don't know. Not sure. Okay. Well, Alex, it's 5 past the hour, 5 past midnight for you. That was amazing. Thank you so much. If it's okay, if anyone has any more questions, email you.
Yeah, please email me.
The chat there, apart from multiplying by 17. We'll get there one day. May we have the same standardized reporting system around the world. But that was great. Thank you for sharing. And hopefully you're ready for the next iteration of the guidelines in 8 years' time.
Oh, well, I don't know. I may defer to someone else.
All right. Maybe we'll catch up in Melbourne when you visit your daughter.
Yeah, exactly right. All right. Well, thank you so much. This was really a lot of fun and a great honor to come. So you all have a great day.
Good night.
Bye-bye.
Thanks, everyone. Bye.
Recording.